I want to thank Dr. Phobi and Dr. Bandari for their kind invitation to give this talk on banded gastric bypass as revisional procedure. In my talk, I will discuss surgical options to deal with weight regain after gastric bypass and my own experience with banded Roux-en-Y gastric bypass for a failed Roux-en-Y. I have no financial disclosures. This is my case mix. Weight regain after Roux-en-Y gastric bypass is not uncommon and is significant in up to 25% of patients. Weight regain increases as years go by, and after 10 years, the percentage of excess weight loss is down to 50% or less. Roux-en-Y gastric bypass is not an operation that lends itself to an easy reintervention to induce significant weight loss. The results of different types of revisional surgery are often short-lived, not significant, and can come at a significant cost of complications. Most publications are short case series. Long-term data are mostly absent. In short, one literally has to maneuver in a minefield. This painting refers to the Oracle of Delphi, where ancient Greeks went to ask the gods for advice, and to a certain extent did applies to revision of Roux-en-Y gastric bypass. Several options to deal with weight regain after Roux-en-Y have been described. These include sclerotherapy, placement of an adjustable gastric band over the pouch, placement of a silastic ring, revision of the gastric pouch and the gastrojejunal anastomosis, distalization of Roux-en-Y, conversion to BPDDS, the Rose procedure, the use of stoma fix, etc. This large series from Al-Bader reports on reduction of the gastric pouch in 170 patients. Excess weight loss at less than 20 months was 29%. The reported complication rate was 15% and the reoperation rate 3%. Dapri and Impens reported an early experience with banding of the pouch using a silicone ring. They treated 6 patients who had regained approximately 10 kilograms, and after 1 year of follow-up, they had again lost that extra weight. There were no complications. Muller reported in 2005 on resizing of the gastric pouch and redo of the gastrojejunal anastomosis. This was a small series of 5 patients. There were no complications, and patients dropped 4 BMI points at 1 year follow-up. Goebel published on the use of an adjustable gastric band as a salvage procedure for weight failure after Roux-en-Y. Again, this was a small series of 11 patients with no complications. At 1 year follow-up, the excess weight loss was 21%, and the patients dropped on average 6 BMI points. A very interesting publication by Dr. Bookwald in 2017 on lengthening of the BP limb to treat inadequate weight loss after Roux-en-Y laid bare the dangers associated with this technique. Like Scopinaro always said, it's very dangerous to add restriction to malabsorption or add malabsorption to restriction. 53 patients were followed up for 5 years. The BMI dropped from 47 to 31. While there was no operative mortality, the complication rate was scary. There were 3 late deaths. The 30-day complication rate was 13%. More than half of the patients suffered late complications, malnutrition being the biggest problem. 43% of patients required TPN at some stage, and a quarter of patients required revisional surgery to reduce malabsorption. Jacques Impens reported his outcomes on revisional surgery for failed Roux-en-Y gastric bypass. They performed a variety of procedures from conversion to distal bypass to a variety of restrictive operations. What is striking again in this series is a complication rate of 20% and a reoperation rate of 7.2%. The leak rate was an impressive 12.1%. Hamdi reported his experience with pouch reduction and refashioning of the gastrojejunal anastomosis in a series of 25 patients. The complication rate was low with only one reoperation for a small bowel obstruction caused by a trocar site hernia. Patients did drop 5 BMI points at year 1, but by year 2, they had not only regained the weight, but put more weight on, as shown here by the BMI number. Another publication from Kashishian reports on conversion of Roux-en-Y and VBG to duodenal switch. Not surprisingly, the outcomes on weight are excellent, a 67% excess weight loss at 30 months, with complete resolution of preoperative symptoms. We all know that the DS comes with a higher complication rate than any other bariatric procedure, and this was reflected in the 13% leak rate for Roux-en-Y patients. Interestingly, none of the VBG patients had a post-operative leak. Conversion of standard Roux-en-Y gastric bypass to a distal bypass for weight loss failure and metabolic syndrome was reported more recently by Gyasi and Kelvin Higa. This series reports on 96 patients. 11 patients had a lengthening of the BP limb, whereby the total alimentary limb length was kept to 250 or 300 centimeters. 7 out of 11 patients developed calorie and protein malnutrition. The subsequent patients all had a revision whereby the TAL was 400 to 450 centimeters. They report an excellent weight loss of 65% at year 3, and patients dropped on average 8 BMI points. The 30-day complication rate in this series was 6.3%. The total reoperation rate was 12.5% and consisted mostly of limb lengthening to tackle malnutrition. A lot of patients were low in albumin, calcium, and vitamin D at year 3. This brings me to my own experience with conversion of Roux-en-Y to banded Roux-en-Y for weight regain. 42 patients underwent this type of revision. 3-year follow-up data were available for 29 patients. The vast majority of these patients were female. The average age was 46, and the interval to revision was approximately 5.5 years. All patients were investigated by means of gastroscopy and barium study. The original BMI before the primary operation was around 46. The nadir BMI after primary bypass was 27.8, and the pre-revision BMI was 38.4. As far as the operative technique was concerned, in 22 out of 29 patients, the pouch anastomosis and proximal small bowel were reduced in size by sleeving that complex. A new anastomosis was created for 24% of patients. In all patients, the candy cane was resected. A bougie 34 to 36 French was used. 9 patients underwent a change of their limb lengths. In 7 patients, the alimentary limb was marginally increased from 80 to 150 centimeters. And in 2 patients, the BP limb was lengthened from 100 to 150 centimeters. A gastric bypass ring or a phobia ring was used in all patients. 27% received a 6.5 centimeter ring, and 73% had a 7 centimeter ring placed. The mortality was 0%. The leak rate was also 0%. Excess weight loss was 88% after 3 years. But I can tell you that following those 3 years, 4 patients did develop again weight regain. The complication rate was 14%. 1 patient sustained a splenic injury during conversion, requiring open surgery with splenectomy. 2 patients had an anastomotic stenosis requiring 1 successful endoscopic dilatation, and 1 patient developed a small bowel obstruction caused by band adhesion treated laparoscopically. This graph shows the weight over time. 3 years after revision, the weight is almost the same as the nadir weight after the primary Roux-en-Y gastric bypass. The BMI graph has got an identical pattern. So in conclusion, revision to banded Roux-en-Y gastric bypass is safe and feasible in selected patients. Weight regain can and will occur in some patients. Like I mentioned before, 4 patients developed weight regain after the 3 years. The pouch size does matter. In all patients, a pouch reduction was essential to allow placement of the phobia ring. Much can be said about limb lengths. I do not think that the small changes in limb length in 1/3 of my patients contributed significantly to the outcomes. Operations can be technically challenging, and one should expect a higher complication rate. More interesting in current times is the use of non-surgical measures to induce weight loss. GLP-1 agonists like liraglutide and semaglutide are now available to induce weight loss, and these medications are currently my first choice to treat weight regain in patients who had a Roux-en-Y gastric bypass. Many thanks for your attention.